If I will ask you, what is the most important advantage of laparoscopy, then what is your answer? Pardon?
Get back to work.
Early get off the work, less hernia. Means, what is your answer? Means early recovery, faster recovery, less scar, less pain, less infection. Am I right? These all answers are correct. But if we will ask you one best answer, then it is improved diagnosis. Most important advantage of laparoscopy is improved diagnosis, because maximum number of the cases what is done today by laparoscopy is diagnostic. 120,000 diagnostic laparoscopy is done every day. And still laparoscopy is one of the best diagnostic tool, because diagnostic dilemma is a big problem of this world. You will be surprised that 18 million diagnostic error happens each year. 18 million. And in United States of America, almost every person in their lifetime get at least one diagnostic error. And due to that, medical error is the third most leading cause of the death in this world. Actually, doctors are killer. Third leading cause of death. See, automatically it came. And this is not I am saying, these are the papers saying. See, British Medical Journal. This is not a blog or a newspaper. This is your journal which is saying that medical journal is the third most leading cause of the death in United States. If United States has this problem, then you can understand about India. You know, it's not one. Every year they did, and still it is same. Even in the 2023 also it was same. All this is medical error. Everywhere this is 2016. If I will put 2024, it will come same. Do you know, once upon a time in Vietnam, all the doctors went to a strike for 3 months and death rate decreases. So immediately after 3 months, they resume their job, because they understood that they will be out of the job if they will continue their strike, because people are now knowing the game of medical industry. But that is done by physicians, not by laparoscopic surgeon, because we are adding in diagnosis. And as a surgeon, we remove only the organ which may not be necessary now to be useful for body. However, many unnecessary surgery also we do. But at least we don't do diagnostic error. Most of the time we add in diagnosis. So we will not go in this controversy. But laparoscopy has a great advantage of improving diagnosis. That's why even for road traffic accident, even in ICU, laparoscopy is preferred to do. Few examples we will see that this young woman came with the vague pain abdomen. Ultrasound has shown that there is a 1 liter blood inside the abdominal cavity. You can see this is all blood. 1 liter blood was inside the abdominal cavity. Suction irrigation was performed. After that, pregnancy test was negative, so she is not rupture ectopic. Anterior cul-de-sac, posterior cul-de-sac, paracolic gutter, Morrison's pouch, splenic fossa, subdiaphragmatic area, all was examined. In between the coil of intestine, everywhere. There was absolutely no any injury. Suction irrigation and thorough lavage was performed to just wash out that. This is Morrison's pouch. We can see some adhesions in the gallbladder, but these are old adhesions. With the gallbladder fossa, with the liver, some adhesions are there, but this is not new one. This is the very old, because those are matured adhesion, not the edematous adhesion. So this is old one. That is also clean. After that, splenic fossa was examined, that is clean. And ultimately nothing was done. One drain was introduced in the cul-de-sac and then telescope was taken out. This is again irrigation suction, and this is a splenic area that is also clean, no injury to a spleen. Once the patient came out of anesthesia, then we told the patient that nothing was found, blood was there, we cleaned it. But can you give some history, because there must be some trauma. Then patient was looking at her husband, and her husband was putting the head down. So what was the story? That 2 days ago they have fight, and husband had pushed her, and a table of the corner of a table had hit the abdomen here, epigastric region. And you can see there is an injury and laceration in this area. And there was some bleeding, but eventually every bleeding stops. Either bleeding will stop or patient will stop. So bleeding stopped. But that blood which is collected, it has created peritonitis after 2 days. Remember, blood immediately doesn't create peritonitis. Third day it appears as peritonitis. Blood is collected 500, 600. If 100, 200, 550 ml will be absorbed. But if huge amount of the hemo-peritoneum is there, then it creates peritonitis. Especially in female it is more. Because little bit PID, pelvic inflammatory disease, this blood acts as a culture medium for bacteria to grow. And in female the blood is very risky. That's why in myomectomy and all, you must put a drain in the cul-de-sac. Otherwise, suppose 2, 3, 400 blood is collected, and a patient has PID, then PID will aggravate and pelvic abscess will form. So this diagnosis was improved by laparoscopy. If for the same purpose you would have done the laparotomy, then it was impossible to look at this epigastric area, JP sternum. You cannot put your head inside and then look like that. It doesn't matter how much big incision you give, you cannot diagnose the epigastric lesion. But thanks to laparoscopy, just turn the light cable down, 6 o'clock, and you can see up. Another example of improved diagnosis is, this is an interesting groin swelling. This patient was admitted as a case of psoas abscess. So idea was incision and drainage. So we will incise and take the pus out. But patient was having some feature of subacute obstruction. So diagnostic laparoscopy was performed, and it was found a case of amioned hernia. Amioned hernia is a rare form of hernia in which appendix will get herniated into deep ring. And we can see here, this is cecum, and this is appendix is going into the deep ring. A small incision was given on the appendix to release the traction, release the incarceration, and then appendix came out. After that, because it was gangrenous, so endo-GI linear stapler was used to fire to do appendectomy. And then huge amount of pus came inside. Immediately it was sucked so that it should not contaminate the other quadrant of the abdomen. And one stitch was just given on the peritoneum, because here we cannot use mesh because it is infected case, and patient was discharged. For the same purpose, if someone would have done a incision and drainage, then this patient will develop fecal fistula, because appendix will get exteriorized and it will create a big problem. Thanks to laparoscopy, that it has improved the diagnosis. So all of you have given a correct answer of advantage of laparoscopy, but if one best answer it will be found, then it is improved diagnosis. Second most important advantage of laparoscopy is less tissue dissection and disruption. Tissue dissection and disruption is 6 to 8 times less in laparoscopy compared to open. In open era, bigger is the incision, bigger is the surgeon. All the great surgeons, they give big incision. But we know that what are the disadvantages of having big incision. You will have incisional hernia, you will have great rectus divertication, adhesion, bowel adhesion. So that's why it is not good to have that much big adhesion. and big incision. So, advantage of laparoscopy that 6 to 8 times less tissue dissection is required. Let us prove by some example. This patient has swollen the dinner fork. She was watching one TV show, magician has put the dinner fork in and taken out, but dinner fork didn't come out. So this is laparoscopy and dinner fork was taken out. A small incision was given, 15 mm, and this fork is removed. And after that, single layer suturing was performed, and that's all. For the same purpose, in young unmarried girl, if someone will give the laparotomy, it is not justified. This is an interesting case of trachobiza. This patient, since childhood, was eating her own hair. Once she reached to 16 years of the age, she has severe pain abdomen, vomiting, and ultrasound has shown that there is a huge hair ball in the stomach. Incision was given on the stomach and this entire hair ball was taken out and it was put in the endo bag and it was removed. So this is very interesting, and these endo bags will make a big difference. Now, not only this, once this ball, big ball was coming out, then telescope was introduced into the stomach. Thanks to laparoscopy, that your telescope can fly over and directly it can reach to the recesses of the body, which our eye cannot. So this is now telescope is inside the stomach, and then it was seen that one very fine thread was entering into duodenum from here. A small thread was entering into duodenum, and carefully this thread was pulled here. In open surgery it might have missed, and this thread was pulled and then huge amount of ball came from duodenum. And basically this was creating gastric outlet obstruction. And this all is bile stained, as you can see. And it was walk over and pulled again through the stomach, back in the stomach. And all was removed. So this is a great advantage of diagnostic advantage as well as less tissue dissection and disruption. And then it was removed and it was sutured. So second most important advantage of laparoscopy is less tissue dissection and disruption. Third most important advantage of laparoscopy is less wound infection. Wound infection is a big problem of open surgery. Every day we are facing, you did cesarean section and wound might be infected. You did myomectomy, wound might be infected. Wound infection is of two types. One is target wound infection and other is abdominal wound infection. Target wound infection means you did cholecystectomy and Calot's fossa has abscess, or you did hysterectomy and pelvic abscess form. Appendectomy, infection to the base of the appendix, that is called target wound. And this is abdominal wall wound, which we can see here. This is abdominal wall wound. Do you know target wound infection is extremely rare in laparoscopy? It doesn't happen in laparoscopy. Target wound infection. You will ask what is great in laparoscopy that it doesn't happen? This is what is great, and that's why it doesn't happen in laparoscopy. These are few big advantages of laparoscopy which doesn't allow the target wound infection to happen. First and most important is interior milieu. Interior milieu is a Latin term, means maintaining environment of inside and cutting it off from outside. This is called interior milieu. Interior milieu means maintaining environment of inside and cutting it off from outside. In laparoscopy, interior milieu is maintained. Once we put CO2 inside the abdomen, after that there is no communication in between the abdominal cavity and outer OT environment. Because inside the abdomen there is a positive pressure of CO2. And whenever there is any leak will be from into out, into out, into out. Many surgeons during laparoscopy, they don't wear mask and cap. Because in their opinion it is not required. Because even if you are talking, even if you are sneezing, you can never put any bacteria inside the abdomen as long as CO2 is in the abdomen. Because always there is a laminar flow from in to out, because inside is positive pressure. You might have seen in our OT when we were performing, there were approximately 50 people inside watching the surgery. And we were discussing the case, talking and describing the procedure. And this is not the first time, we are doing it for last 25 years, more than 25 years, every year. But thanks to laparoscopy, that we don't have any case of infection target wound. Those many people, they will enter in the open surgery operation theatre, patient definitely will get infection. They will never allow you to enter those many people. If you will not wear the mask and you are talking, you are putting all the droplets inside the abdomen. As you know, Staphylococcus aureus is very high load in the nose. And suppose you are sneezing, your mask is not there, you will infect. Hair is falling, you will infect. OT is not properly fumigated, you will put the infection. 80% of the infection in the laparotomy is carried out by external environment. So your external environment is immediately entering into the abdomen in laparotomy. In laparoscopy, it is impossible to put external environment inside because interior milieu is maintained. Second big advantage why infection is less in laparoscopy is carbonic acid. As soon as CO2 comes in the contact with the peritoneal fluid, it turns into HCO3, that is carbonic acid. And this carbonic acid is antiseptic. However, it is acid. So it decreases the pH of the peritoneal fluid to 8, from 7.4 to 5. It becomes acidic. And that's why patient has shoulder tip pain. Because one is diaphragm stretched into hemo-peritoneum and this is irritating the diaphragm, acid. And diaphragm nerve supply and tip of the shoulder nerve supply is same. So patient has shoulder tip pain. But this is just a discomfort, which will be for a few hours. Tramadol is best for that. With tramadol, immediate relief is there. But great advantage is, suppose any bacteria anyhow has entered into the abdominal cavity also, entire peritoneal fluid is now an antiseptic solution. So it will immediately kill the bacteria. Because carbonic acid doesn't allow any aerobic bacteria to grow. That's why in cold drink they put CO2. CO2 is 200 times absorbable than oxygen. And CO2 is 200 times absorbable than oxygen and 20 times more absorbable than room air. So what happened? As soon as CO2 we put inside, it get absorbed by the fluid. And that's why in cold drink, you know, one bottle of the cold drink, that is Pepsi or Coca-Cola, it has 500 ml CO2 compressed. That's why the name is carbonated drink. And it acts as a preservative also, and it make it acidic. That's why once you are drinking, your buccal mucosa get irritated and you are enjoying that irritation. But actually it is dissolving one of the layer of the mucosa of the buccal mucosa because of carbonic acid. It is basically you should use to clean the toilet, don't drink the cold drink. So this is how you should try to use carbonic acid here. Another great advantage of laparoscopy, why the infection is less, is the energy sources. In laparoscopy, always we use energy for dissection. You know, in open surgery, we use energy if we feel that there is bleeding. But in laparoscopy, we want to achieve the preventive hemostasis always. Preventive hemostasis means we cannot afford bleeding. So before it bleeds, we consider every tissue as a potential bleeder. So before we cut, we coagulate. Because once bleeding is started, then stopping that bleeding is more difficult. And once bleeding is not started, then coagulation is easy. So we consider every tissue as a potential bleeder. and then we create preventive hemostasis. And that is a great advantage of laparoscopy. Minimum heat is generated by the harmonic. Harmonic is generating 80 degrees centigrade. This is the minimum heat is generated by harmonic. That is 80 degrees centigrade. And then after that, maximum heat is generated by bipolar. Bipolar is generating approximately 300 degrees centigrade. So at that temperature, even if the tissue is infected, it gets sterilized. Just like in appendix, suppose there is a fecal lead, after tying the knot, we cut by ligation or harmonic, and it will get disinfected. Stump mucosa also will burn and it get disinfected. So energy sources is one of the way to prevent infection. That's why you are seeing in the movie that actor and actresses are in the jungle. An actor get bullet, actress is coming with a red hot knife to remove this bullet. What is the purpose of this red hot knife? Purpose is to fight against infection. However, that much red hot knife will create tissue necrosis. You know, it will burn so much that infection increases. This is only in movie. In real, don't use red hot knife to remove the bullet. It will create more tissue necrosis, because tissue necrosis is also inviting the infection, because it acts as a culture medium for bacteria to grow. More tissue necrosis should not be there. Now, next advantage of laparoscopy, why infection is less C-reactive protein and interleukin 6. See, these two chemical mediators are secreted by our body in response to any traumas. C-reactive protein and interleukin 6, the interleukin 6. So, in laparoscopy, secretion of C-reactive protein and interleukin 6 is many times less than the open surgery. Because these two chemical mediators is secreted by our body in response to extent of the trauma. Like even if you fall, you fracture your bone, or you get some burn or infection, your body secrete C-reactive protein and interleukin 6. These two chemical mediators, they are good for our body in one way, that it gives our body to tolerate stress. But wrong in one way, that it decreases immunity. These are immunosuppressive agents. So in laparotomy, our immunity is decreased. In laparoscopy, it is maintained, because less C-reactive protein and interleukin 6 is secreted. Next advantage is more number of neutrophil and macrophages are on the margin of the wound. You know, if you will take 3 10 mm and 1 30 mm, surface area wise, 3 10 mm has more surface area. If you calculate only surface areas of the wound margin, and because more surface areas are there, in multiple small wound, more surface areas are there, so more number of macrophage and neutrophils are available on the margin of the wound to fight for the infection, and it has a faster metamorphosis, transmigration and regeneration, so there is a better wound healing. Multiple wound is better than a single wound, because it has faster regeneration also and less infection also. Like suppose I have been kidnapped by one terrorist, and that terrorist will tell that I will cut your body because your family is not giving money. So I give you 2 choices. One choice is that I will cut your body, 120 centimeter, and another choice is I will cut your body 45 millimeter. Which one is better? 45 millimeter is better. 5 millimeter that much, 40. Here. Because it will heal faster. And it will heal by primary intention, means by the side. But if we cut 120 centimeter, nobody is there to stitch me because I am kidnapped. And it will make a big gap and it will definitely get infected. Because it will heal by secondary intention from the base. Side it will not heal. So always remember, many open surgeons this give a bad, explanation of laparoscopy. What they say, who don't do laparoscopy, what they say, why are you going for laparoscopy? They will do cholecystomy 4 10 fooling me. 4, 10, 10 mm. Altogether you calculate it is 40 mm. And I am 4 centimeter. I will remove your gallbladder with a 3 centimeter. This is just a propaganda. It is useless. Do you have a house? Yes, I have a house. How do you enter in your house? Through the door or through your window? Patient will say, I always use door. If you have a door, why should you go to the window? They perform surgery with a small buttonhole. They leave your pathology, a stone, everything is inside. They don't remove entire uterus. You will get again cancer, this type of wrong explanation. However, laparoscopy is more complete and more total than the open surgery. And multiple wound infection is, colorectal surgery, 6, 7 ports are used. And then also at the end again laparotomy to remove the colon. But then also it is better than open, because relatively the incision will be smaller and multiple small wound is better than one single wound. So these are the advantage why infection doesn't happen in laparoscopy. Target wound. First day we have discussed about sterilization, and we came to know it is very difficult in laparoscopy to achieve the sterilization. Maximum you can achieve disinfection. If you want to sterilize, either you have to buy the disposable or you should have plasma sterilizer. Hydrogen peroxide plasma, that is expensive. So most of the people, they only do disinfection. But thanks to laparoscopy, in spite of that, infection doesn't happen. So these are why it is. But there is one big problem, that if infection happens, it becomes a disaster. Because there is no way to escape this pus out. In open, if infection happens, it will discharge somewhere. Laparoscopy, it is very difficult. And mostly in laparoscopy, infection happen due to 3B. First B, second B, and third B. First B, first day. Second B, second day. Third B, third day. First B is bleeding. If you did surgery today and within first 24 hours patient is deteriorating, patient has tachycardia, patient has hypovolemia, oliguria, that means most commonly you have bleeding somewhere. And you must try to find out where is the bleeder. If you have damaged the bowel or damaged the bladder or damaged the ureter, you will never have the patient diagnosis possible first day. Bowel perforate karenge, first day there is no way to diagnose. How we diagnose bowel perforation? Pardon? By the gas under diaphragm. And your radiologist will not give you any idea, because gas under diaphragm will be always the remaining pneumoperitoneum. So gas under diaphragm will not show you anything. It will only show you the remaining pneumoperitoneum. So there is no way, there is only one way, that is called regular sign. That is called double wall sign. And regular sign can diagnose the bowel perforation. And it can differentiate in between the bowel perforation and pneumoperitoneum. This is called regular sign. This is regular sign. Here it is called double wall sign. So you will see these all are regular sign. You can see one wall is here, another wall is there. This is regular sign. But the double wall. But for regular sign to see effectively, your radiologist should be present in the CT contrast room. Then only he can focus it on that area. Unfortunately, most of the radiologists nowadays work from home. They never go to the radiation exposure in the, only technician will take the CT contrast and they send with the WhatsApp, and he is talking to another person and seeing the WhatsApp and giving report. No advantage. So, first day only you can have patient deteriorated, it is bleeding. It is rare that bleeding happens second or third day. It happens, but less common. Second B is bile or bladder. If you will injure the CBD, there is no way to diagnose first day. If you will send the LFT for first day, it won't give you any advantage. LFT will come normal. Liver enzymes will not be raised. Ultrasound will not give you any interhepatic biliary treat dilatation. You will confuse. Some fluid will be in the callots that will confuse post-operative reactive fluid. You cannot diagnose 24 hours. Typically 24 to 48 hours, you will diagnose. Even the icterus will start. Even the liver enzyme started increasing. Bile, even bile sometimes start leaking from umbilical port. Because within 48 hours, at least 1 liter bile will come in the abdomen, it will leak. But first day, no advantage. So second B, and that same way, if you will damage the ureter, immediately ureter go to ureteric shock. Immediately you will not see anything. And if you injure the bladder, some leak is there, Foley's is already applied for 24 hours. So bladder will also not leak. Some fluid coming to the vagina, serosanguineous, you will confuse with the serum. But typically second day, bladder injury or ureteric injury is getting recognized. And that is also second B. So if first B is there, like a lot of blood is collected, there is a chance of infection. That's how infection happened in cases of hernia. That a lot of seroma, a lot of blood collected and it acts as an infection. If bile is collected, it will create biloma and infection. If bladder ureteric is injured, it will create infection. And third B is bowel. Third B is third day. This is bowel. You know, bowel is typically diagnosed third post-operative day. If you perforate the bowel today and tomorrow you will not diagnose. Patient has pain, you will consider post-operative pain. After perforation, patient has paralytic ileus, you will consider post-operative paralytic ileus. If you send for X-ray, your radiologist will say gas under diaphragm and query / Hemo-peritoneum. That's abrabad. No advantage. CT contrast, same way, gas under diaphragm and query / Hemo-peritoneum. No advantage. But third day, the remaining CO2 cannot retain more than 72 hours. It doesn't retain, it gets absorbed. And if third day also gas under diaphragm, that means it is perforated bowel. And if radiologist is very smart, then he will put Ziegler's sign. So these three B's are responsible for infection. Not in normal. Remember, I will tell you, even if you will clean your telescope with the tap water and do laparoscopy target wound, but don't tell anybody this. This is unethical, means I am just giving you exaggeration. Why? You will be surprised in many of the small cities, they clean by tap water, put in the formalin chamber at night, formalin chamber, and just use formalin tablets and morning they do surgery. But thanks to laparoscopy, target wound, WHO came to examine the tube ligation camps in India in 1984. At that time, my father was also a very big surgeon, and I have attended one of the tube ligation camp with him. And you will be surprised. Now maybe condition is improved, but at that time how they were doing, I will tell you. And WHO team came to inspect. It was a big news. In one room, ladies will be there, village ladies, just sitting like a cattle, in hundreds, 200 number. Another room will be operation theatre. That is, one school is converted into operation theatre. And one class is waiting, another class is OT. After that, what they will do, they have a ball of Savlon. One lady will lie down with the sponge holding forceps with the bowel Savlon, they clean it. Where? Only suprapubic area, not entire abdomen also. And dress already sari, she is wearing sari already. So they clean it, after that injecting the xylocaine. And after that, direct trocar. Direct trocar, CO2 is never used in the tube ligation camps. Direct trocar. Infraumbilical, 3 centimeter below the umbilicus. Direct trocar, and after that, they use laprocator. Laparocator has in telescope inbuilt fallopian applicator, and in that two fallopian simultaneously you can load. And then it needs naked eye. Laparocator lete aao to naked eye, and then fire. Take it out, trocar out, one stitch on the skin, stand up. Lady will stand her own, and she will go. Another lady is already waiting. When her turn is over, she will come. And they don't change gloves. With the same glove, same Savlon. They dip it, again clean it, and again do the other surgery. Same trocar. That same trocar or fallopian will shake in the ball of Savlon. उसको धो देते हैं ऐसे. Because they have to make a record of 150 in one day. How can they sterilize and how can they autoclave? And how can they put inside us? Nothing. So WHO report was published and team was very much disturbed that this is butchering, this is not an ideal way of doing a sterilization, how India is doing. However, their result is fantastic because after 10th day when all lady came, they were smiling, carrying the last baby also. Because they have multi-parents, carrying it and smiling, no infection, stitch cut, remove, see, again go to work. The credit goes to the laparoscopy, not the surgeon. Because by the time bacteria wants to enter inside, surgery is finished. So there is no any time for bacteria to infect. Quick surgery. And laparoscopy has these advantages. Open has no advantage of this. So target wound infection is rare. That's why we are abusing. In the heavy loaded operation theatre, they don't have multiple instruments. They keep the instrument inside X. By the time patient change, another patient comes, again same instrument they use for second patient and target wound. But port wound infection happens. Port wound infection in laparoscopy is a big problem. And port wound infection happens due to three factors. One is a sterilization factor. You must sterilize the ports. I will tell you, instrument you just put in the side X, no worry. But your ports always autoclave it. Autoclave कीजिए उसको. That's the reason nowadays, atypical mycobacterial infection is increasing port wound. Because one patient was not properly sterilized instrument and she has a tuberculosis or it is that. This is the laparocator. I will demonstrate you that here is the laparocator. This is the laparocator and this is the fallopian is applied. So you will load two fallopian and you don't have camera, you don't need monitor, TV. Just you go and see open and fire. Open and fire. It will do, it will pull the fallopian tube and fire. We will do this during our wet lab. You will do tube ligation yourself. So this is called laparocator. Means it has a laparoscope as well as fallopian applicator. And sometimes these instruments are called reticulator. That is reticulator. Reticulator instrument has advantage. You can articulate also like. So you can do single incision laparoscopic surgery with this single 10 mm port with this laparocator and reticulator. And see if you will move it right outside, inside will be moving left like that. And you can fix it anywhere. See, I have left it, but it is 90-degree fixed. And it can rotate also. I can open and I can open the jaw and jaw is rotating completely 360. So that's why it's called reticulator, because it can rotate as well as articulate. And these all are for single incision. So this is possible to do in the lab. So first infection is B. That is first wound infection is sterilization. Second cause of wound infection is duration. Do you know any surgery which increases the time more than 90 minutes, port wound infection chances are 4 times increases. If you will do the surgery faster, means I am not tell you to do faster, surgery which take less time, like appendectomy, cholecystectomy, simple ovarian drilling, diagnostic laparoscopy, tubal patency test, you will get rare port infection. But surgery, large myoma, very difficult hysterectomy. Like tomorrow we have a very difficult hysterectomy, 22 centimeter ka posterior valve and lateral valve fibroid is there. And the patient has multiple cesarean section. Tomorrow we are going to do TLH. So hopefully it should be good. We'll see how to do. So those types will take a lot because we cannot remove it vaginally. So we have to use morcellator. Morcellator takes time, more than surgery. Am I right? And whenever you have a long duration of surgery, port won't get infected. Why? Margin ischemia means the ports are giving margin ischemia on the wound margin. Another problem is exposed to the external environment for a long time. That is one factor. Third factor is tissue retrieval. Tissue retrieval. If you are retrieving the tissue directly through the wound, you have a high chance of infection. So always use a retrieval bag. If directly you are pulling the appendix without hiding in the cannula and it is rubbing the wound, infection will happen. Gallbladder cholecystitis and directly pulling through the wound without endobag. Even metastasis of cancer also can happen. And infection chances. That's why a study was performed comparing cholecystectomy and hernia. In hernia cases, port wound infection was extremely less. Whereas cholecystectomy cases, through the port from where gallbladder was directly removed, infection chances are high. So port wound infection, laparoscopy will not protect you. Target wound infection, it will protect you due to interior milieu, carbonic acid, energy sources, less C-reactive protein, interleukin 6, and more number of macrophage, neutrophil, and faster metamorphosis, transmigration. But port wound will happen. And remember, any patient up to 6 weeks, if the port infection is not going, strictly in developing country, we should consider tubercular infection. And we should start clarithromycin together with the 4-drug regime of the tuberculosis because it is increasing in number because ports are not autoclaved properly. But altogether laparoscopy has less wound infection. This is the third advantage. First was diagnostic, second is less tissue dissection and disruption, third is infection. Infection also of two types, target wound and port wound. Target wound is 3B, first B first day, second B second day, third B third day. If you did surgery today and third day, typically patient come back to your hospital with the peritonitis, bowel gaya. You should understand. Fourth advantage of laparoscopy, less chances of adhesion. Adhesion is one of the big problem of open surgery. You will be surprised 80% of the laparotomy postoperatively develop adhesion. But thankfully, 90% of adhesions are asymptomatic. Thankfully. But 80% of laparotomy, after laparoscopy, it is rare. And that's why laparoscopy is best for adhesiolysis. This patient has got laparotomy before. She has a severe dyspareunia and pain abdomen. Again, adhesion developed. Then we did robotics. We can see here, this is omentum. These are not a big problem. I am taking forward fast. These omentums are not a big problem. See, the major problem was now coming, this one. You can see this entire uterus, anterior wall of uterus is adhered with the bladder and adhered with the anterior abdominal wall. So this patient has severe dyspareunia because this is the entire uterus here which is adhered with the anterior abdominal wall. And in laparoscopy, this is the adhesiolysis going on. Bladder was separated from uterus and the anterior abdomen was separated. And then interseed was used. So I will take it forward first. It is all separation, 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 and this is interseed. Interseed is covering, this is uterus now, covering the bladder, covering the uterus, and covering the anterior abdominal wall. Interseed is mechanical adhesive barrier, and this is a reoxygenated cellulose. So you can put it oxidized cellulose, and it is put and it will do. In laparoscopy, adhesion is rare. Why? What is great in laparoscopy that adhesion is rare? First big advantage why adhesion is rare, that port wound is away from target wound. If we are doing appendectomy, our ports are in the left iliac fossa. We never put port over the appendix. Because if you will put the port over appendix, what will become our elevation angle? 90 degree. And with the 90 degree, you cannot do anything. So you must go at least 18 centimeter away, so that half instrument will be in, half instrument will be out, and then your elevation angle should be 30 degree. Am I right? So If you remove the appendix, now this base of the appendix, wounded cecum, wounded mesoappendix can never come to the left iliac fossa to get adhered, because left iliac fossa is the port, and over the wounded area healthy peritoneum is there, and healthy peritoneum is the best known adhesive barrier. Healthy peritoneum is the best known adhesive barrier, because healthy peritoneum never allow any wounded bowel or wounded organ to get adhered. If you want adhesion to develop, both the layer which you want to adhere should be wounded. Then only fibroblast collagen fibers will grow and band off adhesion starts. So healthy peritoneum doesn't have affinity with the cecum and appendix. Second is single layer peritonization in laparoscopy is finished within 100 hours, whereas in open surgery it takes more. Within 100 hours single layer peritonization is complete. Open it takes 300 to 500 hours. Many people in the open surgery, they don't close peritoneum. They say peritoneum will close its own. It is true, but it takes more time than the laparoscopy, because it's a large surface area, and in laparoscopy we have a small multiple wound. So within 100 hours it is. Bowel peristalsis is maintained. Do you know, if directly you don't have injured the bowel due to resection, anastomosis or any way, in laparoscopy, bowel peristalsis generally doesn't stop. But in laparotomy, most frequently it stops for at least 12 or 24 hours, sometimes 36 hours. If peristalsis of bowel of patient stop, surgeon peristalsis also stops, because you are always worried यार flatus कब pass करेगी ये patient, तो बड़ा मुश्किल है. She is not passing the flatus, always you are worried. In laparoscopy, just after recovery from anesthesia, we allow them to have liquid and even want to food, but desire should be there. She should be willing to eat. That means GIT is properly functioning, and then we allow. Because of anesthesia, she may vomit, but due to laparoscopy, peristalsis is maintained. Next is humidity is maintained. In laparoscopy, humidity, why? Interior milieu. Interior milieu. And if humidity is maintained, peristalsis is also maintained. And if humidity is maintained, adhesion also doesn't happen. Do you know, when you are doing the laparotomy and you are keeping the bowel outside the abdomen for a few minutes, what are you doing? You are covering with a sponge and putting a lot of saline. Why? Dry serosa is dead serosa. Dry serosa is dead serosa. Serosa can never tolerate even 1 millimeter dry. मर जाता है, dead. Serosa need complete humidity. And if too dry serosa is there, they are dead and they create inflammation, because they have to regenerate. And if two bowel dry serosa come together, interbowel loop adhesion develop. But in laparoscopy, humidity is maintained. So interbowel loop adhesion will never develop. That's why obstruction, postoperative adhesion obstructions are rare. And less tissue dissection and disruption is also decreasing the adhesion, because if tissue disruption means what? In open surgery, you know, if you have to hysterectomy, you need bowel retractor, you need bladder retractor. What do you think these retractors are innocent? Never. If they touch the serosa, touch the bowel, touch the bladder, they are doing tissue disruption. In laparoscopy, we don't need it. Why? Our long cylindrical instrument can fly over to the bowel and directly we can reach to the target where we have to operate. It will reach there. We don't need it. Only head down, right up, left up is sufficient. We don't need any sponge to push the bladder or bladder. No. So we are seldom touching the small intestine or bowel. But in laparoscopy, open, you are doing it. So these are the factors. Rare chances of adhesion is there. But in exam, this will not come. In exam, exception will come. Because everybody knows that adhesion is less. So exception. Sometime in laparoscopy, very bad adhesion develop. Just like in laparoscopy, very bad infection develop. Why bad infection develop? Due to 3B. Am I right? Exactly same way, very bad adhesion develop in laparoscopy. Very bad. And first cause of bad adhesion is leak. Leak. Leak of CO2. Do you know, if you will leak 10 liters per minute for 10 minutes, there may be chances of death. Patient will die. If you will type in the Google, why patient will die? Due to hypothermia. If you will type in the Google that hypothermia and death and laparoscopy, you have a lot of literature, risk factor of inadvertent intraoperative hypothermia and increases morbidity as well as mortality. This is a big problem and it happens, hypothermia. Why? Hypothermia happens because of leak. See, take one example that you are in any hilly area where outside is a snowfall and you are going for vacation and outside is mountain and a snowfall, and then you take shower, and this is a very remote area, there is no geyser. You take cold shower and your body is still wet, and you come in your bedroom and someone will switch on the fan. What will happen to you? You will start shivering. Immediately run and switch off the fan. Who will turn on the fan? Kill me. You want to kill me. Why you did it like that? Immediately you will shout on your husband. The fan क्यों चला दिया? Why? Because wherever there is evaporation, there is cold. That's how cooler works. So your body is wet and this airflow will touch. Further water will evaporate and you will get hypothermia. Am I right? Exactly same way, the CO2 which is in the cylinder is called CO2 because it liquid is converting into gas. It is compressed liquid. And whenever liquid converts into gas, it becomes cold. And this cold CO2 enter into the abdominal cavity and then leaking from one side. What is the rate of leak? 10 liters per minute. And your insufflator will compensate it by adding extra CO2 because all the insufflators are automatic. If the leak is there, it will give gas. Leak stop, it will stop gas. Leak come from other side, it will take the gas back. Insufflator is two directional flow. It is not only pulling the gas in, it can take gas back also. I will discuss insufflator in detail in coming days. So, if that rapid 10 liters per minute for more than 10 minute leak will be there, entire mesenteric blood become cold. And this cold blood enter into vena cava through the portal vein, then go to heart. We are warm blooded, we are not cold blooded animal. So our ventricle fibrillates and ventricular death happens. So a lot of death was happening. Then these company people, they realized that we should stop it. So they started making CO2 warmer. And now most of the branded insufflator is warming the CO2 at 37 degrees centigrade and then they are putting this inside the abdomen. So they have CO2 warmer. So this CO2 warmer has decreased the incidence of death. ये वाला तो कम हो गया, but it has increased the dryness of the bowel. And you know what happened? That suppose you are busy in the myomectomy and your ports are defective, those are wrong ports. It is leaking more than 10 liters per minute for more than 10 minutes. All the bowel serosa become dry. Because now this warmed CO2 creates faster humidity loss. It just like you can imagine it, just like you are putting the bowel outside in the laparotomy and instead of covering with the saline, you are putting a hair dryer over that. So similarly, this CO2, warm CO2, hot CO2 coming from one side and leaking other side. And you don't know how to read your insufflator. Insufflator is compensating it. And you are busy and all the humidity has gone. Entire small bowel is dry. Post-operatively, there will be massive adhesion, interbowel loop adhesion. Because dry serosa is dead serosa. And massive adhesion developed. So this is very important that you should not leak. Leaking CO2, little CO2 will leak anyway. We can never expect to have completely airtight cavity. And little leak is good because little leak will create what? Interior milieu. But more than 10 liters for more than 10 minute leak is dangerous. Now, what are where leak can happen? Tell me 5 places where you can leak. First is your valve is open. So check care that all the valve of and every cannula has a valve. Only the valve of the cannula in which Insufflated tubing is attached, should be open. All others should be closed. Second is reducer, you forgot reducer inside. Taken the instrument out, reducer छोड़ दिया. All the gas is leaking. Third is your skin incision is big. How you will know? Put some drop of saline, you will see bubble. Fourth is outer washer is defective. And fifth is inner seal is broken. I hope Dr. Bhalla has told you how to differentiate outer washer and inner seal. Am I right? So during surgery, all these 5 places of leaking should, all other places are colpotomy and this, that is another story. Because in colpotomy it will leak for only couple of minutes, so that doesn't create problem and you are packing the vagina. But these 5 are constant leaking throughout the surgery it can leak. And your eye should be uninsufflated. If you see leak is more, immediately stop the surgery, stop the leak. If you will not stop the leak and leak is more than 10 liters per minute for more than 10 minutes, your patient may die. If you don't have CO2 warmer. Other alternative is you should be rich. Richer people don't have this problem because nowadays CO2 warmer with humidifier available. And there are a lot of articles published that is benefit of warming and humidifying the insufflator. So these are advances in heating and humidifying the carbon dioxide during laparoscopy. Intra-abdominal humidity, and there is perioperative data has shown that better recovery. But for that you should be rich because you need to have at least 12 lakh rupees is the cost of good quality CO2 humidifier. So if you are rich, you will use it. If you are poor surgeon, your patient is poor, that means you are poor surgeon. In those situations, don't leak. If you don't leak, you don't need CO2 warmer, you don't need CO2 humidifier. Outside is a snowfall, but all the doors and windows are closed. I can maintain the warmth of this room and humidity of this room. So leaking is not only wastage of money, of CO2 wastage, it is bad for patient and bad for you also because you are also inhaling it. So this is first leak. Second, and leak will create adhesion. Am I right? If the death it will not do, it will do adhesion. Second factor of the adhesion is that we are abrupt exit of the cannula. You have a son waiting for pickup. You are doing surgery, February, May, immediately you will say your nurse, okay, it is over, I am going. And she will pull all the cannula. And that cannula will suck the bowel and momentum and create very bad obstruction as well as adhesion. In laparoscopy, that's why, facial closure is not allowed. Port closure is allowed. Some people, they do facial closure. Facial closure is bad in laparoscopy. Here we can see this surgeon is doing facial closure. Facial closure means he is using the small retractors and holding the fascia and closing. Facial closure doesn't decrease the hernia, it increases the hernia. देखिए suture कर दिया with the bowel. Why? Because you will do blind. Because you are holding a small wound, you are holding like that. Your assistant is showing retractor and you are in this way, and always little gas is leaking. That gas will plug the momentum and bowel and you will trap the momentum with or bowel, and this is creating severe adhesion as well as obstruction. So this is not allowed. Port closure means not facial closure. Port closure means full thickness abdominal wall should be closed with the port closure devices like either Veress needle or cobbler's needle or port closure needle. Port closure is not facial closure. Port closure means every layer should be closed. And if you don't close it, you will have a lot of problems. Like I am demonstrating you. Here the surgeon is doing the, not port closure, and suddenly cannula was pulled. Suddenly cannula was pulled. And you can see here that due to that sudden pulling of the cannula, there was entrapment of the bowel, and that entrapment of the bowel has done the big adhesion obstruction as well as hernia. See here, this is all the bowel. Why? Because inside is a positive pressure. So always it will try to grasp the momentum or bowel. And here morsator port was not closed and this obstruction has occurred. So leak of the CO2. CO2 was not taken out properly and due to gush of the CO2 leaking through that wound, CO2 भी जा रहा था तो बहुत सोचा कि चलो हम भी चलते हैं साथ में, and it is got trapped here. Leak is bad. Leak can kill your patient and can create severe adhesion like that. So now you have to cut and pull because there is edema started, so it is incarceration started. Thankfully, it was recognized immediately after surgery, third day, and then it was pulled out. So gangrene has not occurred, and all the bowel is removed. Now it is out, and then port closure will be done, not the facial closure. So this is the cause. So there are two factors creating a lot of adhesion in laparoscopy. First factor is leak with the warmer, create dryness of the bowel, and second factor, abrupt exit. So how to do exit? To do exit, what you do, you should take all the cannula and last cannula, telescopic cannula, you should push the telescope in and then slide the cannula over the telescope and then take the telescope out. So that it will not suck the momentum or bowel. होता क्या है ना, our cylindrical shape of the cannula is sucking the bowel. So push the telescope in and then slide it over, then it will not happen. So these are the two cases where very bad adhesion happen in laparoscopy. And if you take care, it is rare now, adhesion will not happen. Next advantage of laparoscopy, 3 times earlier return to work. If active sport, cycling, jogging, sexual intercourse, all is required. After laparoscopy, on an average, 3 times faster recovery. In open surgery, generally, suppose you are sending the patient, then 6 weeks she cannot play any sports. But in laparoscopy, within 2 weeks she can be playing the sports. On an average. On an average. Next advantage is 6 times less pain compared to open surgery. Pain is very difficult to measure because pain is subjective. You and me both will get same injury. You will be quiet, I am crying. But if I am crying, that doesn't mean that I have more pain. I am making a scene. I am actor. I am crying and you will be quiet. So who will decide? In University of Tübingen, what they did, 600 patients in Germany, Tübingen University has done a lot of study. In that 600 patients they performed with the open, 600 by laparoscopy. And they calculated amount of analgesic consumed postoperatively during hospital stay, 72-hour postoperative analgesics. And it was 6 times less in laparoscopy compared to open. But in the same study, there was very peculiar observation. What was that observation? That attitude to complain towards the pain was more in laparoscopic group because their expectation was very high. You did surgery, hysterectomy in the morning, afternoon you go to the patient and ask the patient, how are you? Patient will say, madam, okay, I'm fine. But never ask second question. Second question, if you will ask, do you have some pain? None of them, they say that no, it's okay. All will say, yes, pain is there. Here also it's pain. Here also it's pain. You say, should I give some injection? They will say, no, I can tolerate. Injection is not required, but pain is there. I thought that it will be painless, but pain is there. You said that there is no pain, but pain is there. So second question, pain doesn't ask. In open group, you don't have to ask. You enter, they are already crying. You will ask the nurse to give injection, some narcotic analgesic or whatever. In laparoscopy, we rarely use postoperative narcotic analgesic. Rarely, 14 phenargum to kabhi dete hi nahi aaj tak. Open surgery, it may be required. In laparoscopy, maximum tramadol. Otherwise, NSAID will take care. And because pain is less. And same patient, why attitude is more to complain? Because they have never undergone same surgery before by open. And in the Google and internet and all is saying that laparoscopy is surgical rose which your surgeon will offer to you. But it is not only rose, it has thorns also. So a little pain will be there. So that's why expectation is very high. However, 6 times less pain compared to open. Next advantage, that less pneumonia. Do you know, this is a problem of any general anesthesia, that cilia get paralyzed. Ciliary linings are important to expectorate the mucus of our respiratory airway. Isn't it? Cilia. Every minute we are swallowing some mucus. Why? Cilia is bringing to pharynx and we are swallowing it. Great. But these filtered by cilia get paralyzed by local anesthesia, sorry, general anesthesia. Nitrous oxide, isoflurane को paralyze कर देता है. And duration of surgery also it is paralyzed. During duration of surgery, once it is paralyzed, then mucus get trapped over the terminal bronchioles and alveoli. And that trapped mucus in the terminal alveoli and bronchioles need to be expectorated after surgery. And for expectoration of these mucus, you need to cough. And in open surgery, coughing means dying. Why should patient cough? Never he will cough. Why? Because coughing is painful. 30 stitches, 4 layers of suturing. Why should I cough? I will not cough. And if I will not cough, I will develop pneumonia. Nurses are also busy. They are not giving respirometer. They are not giving tapping. They are not giving nebulizer. Post-operative risk of pneumonia is very high in open. In laparoscopy, post-operatively coughing has not that much painful because wound is small. And patient is mobilized. Patient can go to toilet, the wired urine herself. And patient can take the posture. Next day patient is at home. Pneumonia doesn't develop. But again, exception. Exception is in pelvic surgery, intraoperative risk of pneumonia is little high. Why? Patient head is 30 degree down. So pulmonary congestion develop. Pulmonary edema due to gravity. And sometimes CO2 pressure and endotracheal tube is not there, NG tube, then the acidic content can be aspirated because of gravity. CO2 is pressing the stomach, acid there. Endotracheal tube is not very tight, she can aspirate. So intraoperative risk of developing pneumonia due to posture and due to CO2 pressure is little high in laparoscopy. But post-operatively and all around peri-operative you will calculate, it is very rare. Next advantage of laparoscopy is less DVT. DVT is a big problem. Deep vein thrombosis happen because our calf muscle vein doesn't have valve. So it needs compression of our muscle to push the blood up. And these get thrombus. And this is called deep vein thrombosis. From here this thrombus will come. It may be trapped by our saphenous filtering system. However, if it not stopped here, then it will go to common iliac vein, then it will go to vena cava, then it will go to the right atrium, then it will go to right ventricle, and then it will go to pulmonary artery, and then it will go to lung, and it create thromboembolism. Once it go to the lung, after that it create first pulmonary hypertension. And once pulmonary hypertension happen, then right heart failure happen first. Because right ventricle started dilating because pressure cannot. And subsequently left heart failure will happen. And then patient will go to the hemodynamic collapse. If patient get hemodynamic collapse, immediate ICU is required. This is now DVT has already formed here. Right heart is dilating and dilated now. Pulmonary hypertension, and then blood is not returning adequately and hemodynamic collapse. Once the patient is immediately diagnosed that DVT has occurred, you should bring it to the ICU and immediate surgery is required. For that, direct oral anticoagulant can be given, vitamin K antagonist and low molecular heparin, and if possible, reperfusion surgery. Reperfusion therapy means उसको thoracotomy करके निकालना पड़ेगा. It is very difficult. Otherwise, 1 in 10 patients they die. So DVT happens. 0.1% is the incidence of mortality in major surgery due to DVT. Means in 1,000, 1 patient they die due to DVT in open surgery. Laparoscopy, it is rare. Why? Post-operatively patient can easily bend the knee. She can walk next day at home doing the work. Chances of DVT is rare. But again, exception. Intraoperative risk of DVT in upper abdominal surgery is higher in laparoscopy. You know, DVT is less common in gynae. Why? Patient is head down and calf is supported by lithotomy. Calf is supported. So it is anti-gravity area. Blood उसमें नहीं जमा होता है. Blood doesn't stagnate. It return back. So less chances of DVT in gynae or pelvic surgery. Unless until patient is taking oral contraceptive, a smoker, morbid obese, then only. In general surgery, in upper abdominal surgery like fundoplication, hiatus hernia, bariatric surgery, Hiller's myotomy, your head is 30 degrees up. So due to gravity, blood gets stagnated into the calf muscle. So for upper abdominal surgery, intraoperative risk of DVT is high. And another problem is the CO2 is decreasing venous return also due to pressure over vena cava. So once venous return decreases, that's why whenever you do bariatric, fundoplication, Hiller's myotomy, then you must give low molecular weight heparin subcutaneously or IV. 5000 international unit is enough, and that is to prevent DVT, or you use a spiral stocking or DVT pump intraoperatively to prevent the DVT. So intraoperative, but altogether if you will calculate in laparoscopy, DVT is very less compared to open group. Why? Open DVT develop postoperatively. Why? Because of this pain, patient will not move. And nurses are not taking care. Patient is bedridden for 2-3 days. After major surgery, Whipple's procedure, colorectal, patient will not die due to the surgery, die to DVT. But in laparoscopy, post-operative risk is not there. Intraoperative risk is little high. So this is another advantage of laparoscopy. Another advantage is less immunosuppression. Open surgery is itself a cause of decreasing immunity. Do you know this macrophage, by many of the hematologists, they consider it is not a blood cell. It's a memory cell. You know why? Your grandfather has got any bacterial infection. Your macrophage still remember that bacteria which has infected your grandfather. And even that bacteria comes to you, it will try to phagocytize because it will consider as an invader. Why? Because it has a mannose binding protein, and this mannose binding protein recognizes the bacteria link on the bacteria. But this C-reactive protein is blocking this mannose binding protein, and then our macrophage is useless. So that's why immunosuppression is a big problem, and in laparoscopy immunosuppression doesn't happen further. That's why laparoscopy is gold standard for HIV patient. Because HIV patient, if you do laparotomy, they may die due to the laparotomy wound infection. Am I right? And already immunocompromised, they cannot tolerate further immunosuppression. But in laparoscopy, there is no immunosuppression. And the butylaldehyde is very fast to kill the HIV and hepatitis B virus. So this is another advantage, less immunosuppression. Next advantage is, and last is cosmetically better. When laparoscopy was started, this was the first advantage, that less scar, less better cosmetically. But today we have discussed so many advantages which was much valuable than cosmetic advantage. But it is last but not the least, because everybody wants to look beautiful. In laparoscopy, that's why it's called band-aid surgery. You can see it's such a bad scar for cholecystectomy. Start from anterior superior iliac spine up to jiffy sternum. And big surgeon, they always give big incision. Here it is a, you can see duodenal perforation scar. And it is true, that is that much big laparotomy. And after that, there is a two drain also. This is drain. In laparoscopy, cholecystectomy, if you do after 6 months, a scar rarely visible if you respect Langer's line. So always Langer's line should be followed. This is a very bad scar. You can see myomectomy, young unmarried girl. What will be the situation? She has that much bad. But laparoscopy, rarely a scar will be visible. Some surgeons over the inferior crease of umbilicus, they give vertical incision. Do you know around the umbilicus, Langer's line is smiling, not vertical. यहाँ का Langer's ऐसे होता है. So that's why a smiling incision should be given. If you give vertical incision, a scar will be visible. However, if the girl is intelligent, she can wear these type of skin piercing ornaments to hide those scars. But unfortunately, no ornaments available in the market to hide the laparotomy scar. Laparoscopic scar you can hide, especially umbilical port. And if you give a smiling incision, this also will not happen. So cosmetic outcome is very good. Last advantage is early discharge in pandemic. Do you know during COVID, our training was stopped for entire 1 year. We have never stopped in training in last 25 years, never. Every month we have course. But in COVID period, there was no transport, government has locked down, so it was closed. But you'll be surprised, our patient input become 5 times more. You know, patients were very reluctant to go to the corporate hospital like Max Fortis Gangaram because they were afraid that I have acute appendicitis or cholecystitis, I will go and I will get COVID because they were treating COVID patient also. So they were coming to us because they came to know that we do only laparoscopy. So they were sure that they are not dealing with any other specialty or any other infected cases. And footfall is not there. We have most of our patient is referred patient. We don't have an OPD. Directly patient come for laparoscopy. It is not like that we are doing OPD and then filtering the patient for surgery. Directly patient know that they do laparoscopy, they come. So directly they were coming, we are doing RT-PCR and discharging same day. And that is great for laparoscopy. That in the war time, natural calamity time, viral pandemic time, laparoscopy is great. Because faster turnover and no contamination port wound, laparoscopy is considered as a green surgery. Green surgery. Do you know, in America, in one laparoscopy, they have 20 kg consumables. 20 kg, 20 kg consumables. Like, all their instruments are disposable. All their ports are disposable. Am I right? All their drapes are disposable. Patient seat is disposable. Surgeon's gown is disposable altogether. So they calculated in one patient how much consumables, wastage that need to be incinerated by biomedical refuge is 20 kg. And do you know in India how much? 200 gram. Only 200 gram disposable we have in one laparoscopy. Because we don't throw anything. What we throw? Only gloves, mask, some of the sponge which we use to clean. Am I right? And patient will go to the washroom and on the tissue papers, that's all. Our gown is sterilizable, patient drapes are sterilizable, most of the places. And gloves only we use it, and all instruments are reusable. So it's green surgery, it creates less pollution to this world. Less open a lot of pollution, everyday dressing ho raha hai, ye ho raha hai, wo ho raha hai. And that's why it is very good for pandemic surgery. So this was regarding the advantages of the laparoscopy. So disadvantage I will discuss and complication, that is more important. Disadvantage and complication is more important. That I will discuss tomorrow.